Okay. So it's important for us to understand that women with multiple pregnancies receive insufficient care, especially in our setting in Africa. And that is the thing that we are trying to correct as we are teaching people to scan multiple pregnancies and to understand more about multiple pregnancies. So we need to also understand that even the babies that are born from pregnancies with from women with multiple pregnancies, they are at an increased risk of dying in utero and even after delivery. This is as compared to singleton births. This is mainly because these babies are delivered earlier, hence they have a lower birth weight, and due to the fact that their gestational age at delivery is lower compared to singletons, they have challenges that are related to prematurity. So if we are to compare, say the twins, if we are to compare the outcomes for monozygotic versus dizygotic twins, you find that monozygotic twins have poorer survival rates. This is because of the complications that are specific for monozygotic pregnancies. So it's important for us to understand the classification of multiple pregnancies based on chorionicity. I've already mentioned that these women receive insufficient care in our setting, mainly because the guidelines have been silent on the special care that these women need, and also there hasn't been any specific training for scanning women with multiple pregnancies. It is against this background that the Fetal Medicine Unit decided to establish clinics that are specific for scanning women with multiple pregnancies. So we have 3 multiple pregnancy clinics that run every week, 2 at Sali and 1 at Parenyatwa. These clinics are manned by fetal medicine midwives, specialist obstetricians, and our fetal medicine specialist, Dr. Veringa. In these clinics, so far we have scanned twins, we have scanned triplets, we have scanned quadruplets, we have also scanned quintuplets. The women will be coming from both the public and private sectors. Okay, so before I proceed, it's important also for us to understand that there are some important prognostic factors when managing women with multiple pregnancy. These are the gestational age and the chorionicity. So we need to determine the gestational age correctly, because that's what is going to determine what we are going to do at what point in that pregnancy, when we are going to intervene, when we are going to deliver that pregnancy as well. Because the delivery for multiple pregnancy is timed. We rarely wait for spontaneous delivery. We have to time because of the complications that I'm going to mention later. We also have to establish the chorionicity because of its significant prognostic value as well. The chorionicity is what is going to determine what we are going to do for that particular pregnancy. It's going to determine the intervals at which we are going to be reviewing that woman. It's going to determine the plan of care, the antenatal plan of care that we are going to follow. It's also going to determine the complications that we are going to face or that we should anticipate to face for that particular pregnancy. Hence, the complications that we should screen for at each point when we are seeing that woman. It's also going to determine the timing of delivery as well. So we can see that chorionicity determination is very important. Yet, unfortunately, our women present late. And some of them, they are seen at local clinics, they are never referred. They are then referred at 36 weeks, where it's very difficult to determine the chorionicity. So I've already explained this point where I said it's the most, chorionicity is the most determinant factor of surveillance, complications, and the fetal outcomes. So in our 2 units, we start following up women with multiple pregnancies in the first trimester. We start off with the first trimester scan that we perform around 11 to 13 weeks plus 6 days. At that scan, we confirm the type of gestation. Is it indeed a multiple pregnancy? There are some women that come with the diagnosis of multiple pregnancy, and then we have to reduce it to singleton because of the errors that happen during scanning. We confirm viability as well. We confirm the pregnancy location, and once we have confirmed that it's a multiple pregnancy, we assign chorionicity for that pregnancy. For assigning chorionicity, we use 2 or 3 methods. At the first trimester scan, we mainly use 2 methods. The first method, we count the number of placental masses that we can see on the scan. Okay, so in this image here, we can clearly see that there is 1 and 2 placental masses. So during the first trimester, it's clear and straightforward in most of the pregnancies. You can actually see the number of placental masses that are that pregnancy. If the placental masses, or if they have already fused, or if you can only see 1 placental mass, you can actually assess the inter-twin membrane thickness. You identify the membrane that is between the 2 sets. You follow it all the way up to the point where it's inserting on the placental mass. Then you assess the thickness. In most of the cases, it's difficult to measure. So it's rather a subjective assessment. And then it depends on your experience as well. But you can see that if it's a monochorionic pregnancy, the intermembrane thickness is very thin, like what is shown in this image here. So it's very thin. Yet in a dichorionic pregnancy, we have a thick intermembrane thickness. You can actually see that it's peaking from the placental mass and looking like the lambda sign. This is what we refer to as the lambda sign. And then this thin one is the T sign. Okay, so at that point, we also label the fetuses. If there are 2 of them, in our unit, we say the fetus who is on the maternal right side is twin 1 or twin A. And then the fetus who is on the left side is twin 2 or twin B. And that is if they are lying longitudinally. Is that clear? 2 babies lying longitudinally, whether cephalic or breech, the one on the maternal right side becomes twin 1 or A, the one on the maternal left side becomes twin 2 or twin B in longitudinal position. But if they are lying in a different position, one of them can be in longitudinal position, the other one can be transverse. We say the one who is closest to the maternal cervix is twin 1. And then we label the other ones randomly. Is that clear? So if there are 3 babies and one of the babies is lying close to the cervix, that one is twin 1. And then if the other one is on the maternal right and the other one on the maternal left, this one becomes twin 2, that one becomes, triplet 2, that one becomes triplet 3. Do you understand? Okay, so this is important because we need to follow up twin 1 as twin 1. So fetal labeling is important. We need to follow up on the growth. We need to follow up on the Doppler studies. We need to examine for abnormalities, and all the things for twin 1 should be assigned to twin 1. If you don't label them correctly, you end up cross-scanning them. So sometimes it's difficult to say maternal left, maternal right. You have a boy and a girl. So you can say twin 1 is the boy and twin 2 is the girl. When you scan them next time, you know that I scanned twin 1 as the boy. Then you assign the biometry for twin 1 for the boy, the biometry for twin 2 for the girl, and you follow them up as such. Sometimes it's difficult, they are neither on the left or the right, and both of them are of the same gender. You can use the placental location. If they are dichorionic, you say the placenta that is on the fundal region. You examine thoroughly and you see that this is for the twin who is lying on this side. And the placenta that is on the left lateral margin is for this twin. And next time when you scan, you are also using the placental location to assign the correct assessment for the correct twin. If there's one placental mass, they are of the same gender. Things are difficult. You can use the cord insertion position. Okay, fine. And then again, at the first trimester scan, we screen for chromosomal abnormalities like trisomy 13, 18, and 21, and also Turner's syndrome. We also assess for major fetal abnormalities like holoprosencephaly, gastroschisis, omphalocele. I think someone is going to present on that. We also assess for preeclampsia using uterine artery Dopplers. We also just check for adnexal masses. Okay, so once we have confirmed that this is the multiple pregnancy, we need to decide, we need to give the correct diagnosis. Is it a twin pregnancy? Is it a triplet pregnancy? Is it a quadruplet pregnancy? Is it a quintuplet pregnancy? You go on to classify, now using the chorionicity and amnionicity as well. Okay, so for twins, we can only have monochorionic and dichorionic twins. The monochorionic can be further classified into monochorionic diamniotic or monochorionic monoamniotic. And then we can have the dichorionic diamniotic. The triplets can be trichorionic, triamniotic, dichorionic, triamniotic, and they can also be monochorionic, and the fetal sex can be in various relationships. So it's important for us to be able to do that. And if we are not at the next level of care, because we have agreed that chorionicity is the most important determinant factor of the outcomes. Okay, so now we'll take the term for the monochorionic twin. We said we start scanning them at 11 weeks, up to 13 weeks plus 6 days. From that initial consultation, we see them at 16 weeks. At that point, we start following them up every 2 weeks. At each assessment, we are checking for fetal growth, Doppler studies, amniotic fluid volume, fetal bladder volume and the cervical length every 2 weeks. You'll find that by doing this, we are actually screening for the common complications with twins. At 18 to 22 weeks, we perform a fetal anomaly scan, and into twin transfusion syndrome, we also perform a fetal echocardiography. And the timing of delivery for monochorionic twins is 36 to 37 weeks if it's a diamniotic, monochorionic diamniotic, and 32 to 34 weeks if it's monochorionic monoamniotic. The complications that can occur in a monochorionic pregnancy include twin-to-twin transfusion syndrome, twin anemia polycythemia sequence, selective fetal growth restriction, selective single intrauterine fetal demise, preterm labor, and TREP. We have to remember that TREP is a rare complication. I said we are assessing the fetal growth, and when scanning monochorionic pregnancies, we flight the two images from the two fetuses on the same screen. So we are using a bi-screen where we flight the image from twin 1 and the image from twin 2 on the same screen. So on this image, it's an example of the fetal abdomens. Say this one is for twin 1 and this one is for twin 2. So we use different colors so that we know that this is twin 1 and this is twin 2. So you can see from these two images that this abdomen is bigger than this one. So we are doing this real time as we are scanning. You can actually see that twin 1's abdomen is bigger than that for twin 2. And from that point, you start to look for the things that you are supposed to look for. I like to go through the scanning for twin 1. When you are done, you go through the scanning for twin 2. Then you notice that there's a discrepancy, and then you have to go back and recollect things. So because it's one pregnancy, a monochorionic it's one pregnancy, we scan the babies at the same time. And when we are assessing even the amniotic fluid, we also do it on the same image so that we can see that there is polyhydramnios in this sac and reduced amniotic fluid in the other sac, or we can actually see that the amniotic fluid volumes are comparable. So we are doing it real time. We have assessed the biometry, and we have an estimated fetal weight for each twin, and we calculate the discordancy for fetal weight. The machine should do this for us, and it should show us if it's more than 25%, then we have picked that there's a discrepancy in the estimated fetal weight, or something going on. We go on to assess the amniotic fluid volume, and if there's a discrepancy of more than 6 centimeters, then we also confirm that there's something that is going on. We assess the fetal Dopplers as well, the umbilical artery, the cerebral artery, and the ductus venosus for both twins. And as usual, we are assessing what we look for in the umbilical artery. I think someone has explained this. But specific monochorionic twins, we also want to assess the peak systolic velocity. In addition to all the things that you have been told by Mrs. Zanga and Dr. Tlachani, also have to assess the peak systolic velocity for this type of pregnancy so that you can pick anemia, conditions that cause anemia. So for the purposes of this discussion, I'm not going to go into details on the twin-to-twin transfusion syndrome, but I just want to highlight that it's an important condition that affects monochorionic pregnancies where there is transfusion of blood at the level of the placenta from an artery of one twin to the vein of another twin, resulting in differences in amniotic fluid volume and circulatory volume for both twins, and that will result in serious complications. So for us to pick this, we need to assess the fetal weight, pick a discrepancy of more than 25%, or if one of the twins has fetal growth restriction or an abnormal umbilical artery Doppler, then we should start suspecting twin-to-twin transfusion syndrome. If also there is a discrepancy in the amniotic fluid volume, where we have one sac fully hydramnios, another one with reduced amniotic fluid volume, or if we have a discrepancy of at least 6 centimeters, then we have diagnosed twin-to-twin transfusion syndrome. It's staged from stage 1 to 4. In our units, at the moment, we are able to manage this condition. We are able to do amnio reduction for stage 2, more than 26 weeks, and we are not yet able to do laser ablation, septostomy, and cold coagulation, but we are hoping that in the future we'll be able to do that. So if you pick this condition where you work, please send these patients to the fetal medicine unit, either at PARI or SALI. We are able to do some things that can help them push the pregnancy a little bit and improve the gestational age, hence the fetal outcomes. The selective fetal growth, the other complication that we see, this one, we pick it if there is a fetal, an estimated fetal weight discordance of more than 25%, or if one of the babies is small with a center that is less than the 10th center, or abnormal umbilical artery PI more than the 95th center. So we pick this one and we follow them up every week, assessing the fetal weight, assessing the Doppler studies, and then we deliver according to the gestational age and Doppler studies of the smaller twin. Okay, I also mentioned that we can have single intrauterine fetal demise. The causes are different. Probably maybe there was twin-to-twin transfusion syndrome that wasn't picked, or there was severe selective fetal growth resistance that wasn't picked, or maybe some discordance for fetal abnormalities. All these things can result in single intrauterine fetal demise. We don't rush to deliver. If the gestational age is still really preterm, we don't rush to deliver these pregnancies. We monitor them every week, assessing the Doppler studies, and then every 2 weeks, we'll be checking the fetal weight. We also have to perform a central nervous system MRI scan of the survivor to check for neurological complications. In our setting, we are not yet able to do this, but I think we know that the equipment is there at Harare Hospital. At the moment, we just do advanced neurological ultrasound scanning for these pregnancies. So we monitor them until they stabilize, and then we deliver. Maybe if the gestational age is more than 35 weeks, or if the Doppler studies are getting worse for the surviving twin. So the take-home message is don't rush to deliver. If the pregnancy is really preterm, don't rush to deliver, because you are going to lose the survivor as well. So there's a benefit in trying to put the pregnancy as much as possible, as long as you are monitoring the pregnancy and you are confident that you can assess the fetal weight and the Doppler studies as well. It's good to refer women with such a complication. It's important for you to refer them to us so that we can follow them up properly. I mentioned that we can have twin anemia polycythemia sequence, probably for the registrars, who benefit of the registrars who are in this meeting. You're gonna from twin-to-twin transfusion syndrome. The mechanism is the same, but this time we are having small deep-seated arteriovenous connections, and we have one baby transfusing the other one slowly over a long time. And then we end up having one baby with an increased hemoglobin count and the other one with a low hemoglobin count. I hope you can relate to the first condition that I explained, twin-to-twin transfusions, where I said it's a problem to do with volume. You end up having one baby with hypervolemia and another baby with hypovolemia. So that's where the difference is. In this one, in this type of pregnancy, it's to do with the blood count. So if we examine this pregnancy, we can pick a discordancy in the estimated fetal weight. We slow flow of blood for the twin who has polycythemia, and increased flow of blood for the twin who has anemia. So those are the things that we are looking for: middle cerebral artery, peak systolic velocity, and an estimated fetal weight. Thank you. So we can also have the TREP sequence where we have a pump twin who is sending blood to both twins, and the other twin is usually an abnormal looking twin where you cannot see the head, just see the torso that is usually looking abnormal, and the limbs also may also be maldeveloped. And if you notice this, you have to send them to the fetal medicine unit. Don't rush to deliver. We can actually follow them up. We can actually do some things that can help this mother at least to take the one baby home. At this point, I'll move on to Dichorionic twins. These ones, we start seeing them in the first trimester as well. And then after the first trimester visit, we see them for the second trimester scan at 18 to 22 weeks. Thereafter, we see them every 4 weeks, where we assess the fetal weight, assess for any estimated fetal weight discordancy. We also assess the fetal Doppler studies and also measure the cervical length to screen for preterm labor. The timing of delivery for uncomplicated dichorionic twins should be at 37 to 38. The common complications that we have diagnosed in this type of twins include selective fetal growth restriction, which is the most common. Of the complications that I mentioned earlier, discordance for fetal abnormalities, including even chromosomal abnormalities, preterm labor, and preeclampsia. If we pick selective fetal growth restriction, we see them every 2 weeks, where we are following up on the growth and also assessing the fetal well-being using studies. We advise delivery when the gestational age for the pregnancy has reached more than 35 weeks, or if the smaller baby is not doing well and the Doppler studies are worsening, then we consider delivery. If there is single intrauterine fetal demise, again, we see them weekly until stabilization. Then we start to see them every 2 weeks, assessing growth and Doppler studies as well. And then we treat this pregnancy as we treat on pregnancy. And then if there are no problems, you can actually wait for spontaneous labor. And we advise cesarean section based on For the mode of delivery, we usually liaise with the obstetric team, and we have to know that for our setting, the best outcomes are with both dichorionic and monochorionic pregnancies. We get the best outcomes with cesarean section because we don't have enough tools to monitor multiple pregnancies when they get into labor. We manage them as we do for the monochorionic twins. We see them in the first trimester, then every 2 weeks, where we are assessing for the same things. It's easy. Fetal weight, Doppler studies, cervical length. We are in the second trimester, we do a second trimester scan, and the common complications that we see are just similar. Restriction, twin-to-twin transfusion syndrome, single intrauterine fetal demise, preterm labor, and these ones we aim to deliver at 32 to 4 weeks. So same applies to quadruplets and quintuplets. And the timing of delivery for quadruplets is 30